Be next. Barron, Dr. Mark Barron is going to be our next speaker. And Dr. Barron is the director of PADRAC over at the VA, which is the McGuire Veterans Medical Center. And then Dr. Jim Bennett will be our third speaker, and he is the new director of VCU Parkinson's and Movement Disorder Center. So we are so happy to have all three of them here today. If you look in your package, you will see a list of their bios. They are so qualified to be here today, and we are so happy that they're here. So please give them a warm welcome.
Starting off with a bang. And is this on now? How about that? Can everybody hear me? No. Who knows how to work this? How about that's on? I'll stick with that. Hello, everyone. I'm Katherine Holloway, as you've heard, and I'm the neurosurgical part of the PADRAC. Dr. Mark Barron's our director. And I'm coming to talk with you about some of the research and the updates that we've been working on, some of the things I'm very excited about and have been working on for quite a few years. I've been with the PADRAC since its inception, and I'm very happy to be part of the inception of the VCU Parkinson Center. But we've been working in the field for quite some time, and hopefully some of the things that we're developing can be helpful to you all. So what I'm going to talk about is the updates in neuromodulation disclosure. I do get paid by Medtronic to teach other neurosurgeons how to do the procedure, and I have some grants to do research in this area. So what I'd like to talk to you about is one of my biggest efforts has been to improve the comfort, ease, and accuracy, as well as the outcome of DBS surgery. And then I want to talk to you about the results of a very large trial that has been ongoing, and actually the follow-up is ongoing still. But we have finally the results of the CSP trial, and I would like to talk with you about that. And then I'd like to talk to you about some of the efforts we're doing to fine-tune the surgery. We've gotten the general theme of things, but I think that we can dial in and get an even better result as we start to understand what's happening in these areas of the brain. And then I just want to touch on something new that we're getting into. We haven't actually started, but non-invasive ways of stimulating the brain and seeing if we can have an effect on some of the symptoms that we haven't been as successful with implanted deep brain stimulator. So one of the first efforts now, if some of you have been coming to these meetings for some time, then you've heard about this technology where we have replaced the frame, which you see here. Not a pointer. There it is. So this is the frame, and we replaced that with the frameless system here. So instead of having this on your head, this is actually what's attached to the head, and you don't have to be bolted to the table during the surgery. And that was all to improve patient comfort, and also I've always thought that looked a little intimidating. So this is just a little snippet of someone having the surgery in this manner, and we're working at the back of the head there. We're doing microelectrode recording. You're going to see Dr. Barron is interpreting these signals. Here's Dr. Barron looking at the microelectrode recording, and he's drawing out maps and helping us decide the best spot in the brain. You have see a lady without a frame on her head, and she's got a tremor. She's Parkinson's, and she's got a bad tremor, and that's the easiest thing to show in the video. We're turning it on slowly, increasing the voltage, and eventually we get the tremor to stop. We have the ability now to do intraoperative scanning, and that's one of the things I'll talk about a little bit. And that allows us to see where we are in the brain in real time in surgery. And this means that we can eliminate some of the surgery because we know where we are. We don't have to go look somewhere else. In addition, if we don't have surprises after surgery, saying, oh, I thought we were here and it turns out we're there. We know everything that we want to know about in surgery. We know what the physiology says, we know how the patient responds to the stimulation, and we know on a CT scanner where we are. But I think the best thing is, as I developed the frameless system, I replaced that big frame with some little screws that go on the scalp, and I've now been able to incorporate those into the main part of the operation. And so I think that has improved the comfort level of the surgery as well. So as you can see, we can use all that information and help folks. This is the newer device that we have that Dr. Bennett was so helpful in getting over at VCU, as well as where we've had it at the VA. And this is very convenient. It allows the patient to sit up. The last video, the patient had to lie flat with an older device. Now the patient can sit up a little bit and be more comfortable. So with all of these things, we've gotten better patient comfort. Then I want to move on to the results of the trial. So this was a trial done with 6 VA university partners across the country. And we've been working on it since, I think, 2001, 2002. And the first part of this study was to compare best medical therapy to surgery with end-stage Parkinson's. So we're not talking about the initial onset of Parkinson's. But at the end stage, when a lot of the day is spent off, the pink, there's a lot of time spent on with dyskinesias, and a much smaller portion of the day, this green is the good part of the day, so 7 hours. If you keep tinkering with the meds over 6 months, even excellent people like Dr. Barron and Dr. Bennett, even with all that work at 6 months, you look exactly the same. But what we saw was that if we do surgery, we increase that good time significantly. So that was the first publication. That was back in 2009. So we established that, yes, indeed, deep brain stimulation does give you a better quality time during the day. And then the next part was, I like this cartoon. I took that from somebody else's publication, Dr. Kelly Foote and Mike Okins, but it shows the matchup between the GPI and the STN. That was our big question. We had 2 spots in the brain that we could go to that would treat Parkinson's, and actually at the outset, STN was really considered the big guy. GPI had gone off the map. That was pallidotomy. That was old news, and everybody thought the subthalamic nucleus was the best place to treat Parkinson's disease. But in fact, what we found was that the 2 targets work pretty identically well. There's very little difference between the 2. So again, we're looking at the green time is the good part of the day when patients are on without troubling dyskinesias, and we see it increases with GPI stimulation at 2 years. And we see the same thing happening with the STN. You do see a little bit of difference in the medication. The medications drop a little bit more in STN than they do GPI. So there's a slight difference in that. And, but there's nothing like a video to show you the true difference. So this is a gentleman who will eventually undergo subthalamic nucleus stimulation. At this point, he is off without his medications. You'll notice that he's quite emaciated. He's got a bad tremor. Oops, sorry. Can you click on that video for me? There we go. So we'll have him walk again. Sorry about that. So he's slow, but he actually looks pretty good until he gets to a turn. So again, this is preoperative, off of medications. He fascinates. And you can see his right hand tremoring if you look closely. And this is him on medication, which made it much easier for him to walk. But as you can see, he's got significant dyskinesias, and those bandages on his arms are because of all the falls that the dyskinesias caused. This is him 1 year postoperatively, again off of medication. And you can see that he's walking well. He's even put on a little bit of weight, not much. He's still rail thin. But I think what's most interesting is the next video, which is our last follow-up, 7 years after stimulation. And this is off of medication. So he's still walking independently without a cane or walker. He's a little bit slow and unsteady in the turns. And then we'll show you with him on medication. And so that medication gives him a little extra speed, so it helps the two work together. But 7 years out, and we know from patients who have had their batteries die suddenly that these patients, because they were end stage, then when they came to us, would not likely be alive at this point because they would be so frozen with the Parkinson's. So next is GPI. This is a gentleman preoperatively off of medication, so he doesn't have a stimulator yet. And he has very tiny steps. And this is 1 year after surgery, off of medication. He's got a little dystonia in his arm. And this is him 5 years after surgery. I think we got him dialed in a little bit better over time. All right. One of the neat things about deep brain stimulation is the tune-up part. So we have folks come in, their disease has progressed. Can you switch to the next video? This is Miriam doing programming, you recognize. This is a gentleman who's come in, and he has arisen in the last few months a little bit of problem with festination. Okay. Oh, and there's Bob Gordon's right there. He was our star right there with the tremor. But you'll notice in the right-hand video over here that he's going to festinate through the doorway. There, and if you switch to the next video. And here, with a little bit of programming, he will now be able to pass through that doorway. So in a 10-minute, 15-minute visit, we can adjust to keep up with the disease. And I think that's one of the most powerful things about deep brain stimulators instead of lesions. I think you're going to have to help me get to the next slide. And so some of the other things that we're doing is we're trying to fine-tune the location. This is a map created using the data from many patients. And what we're finding is areas, the red areas are good and the blue areas are bad. And we're finding that we can pick and choose between those two. Speech has been a big problem, and we find that there's a good speech area and a bad speech area in the subthalamic nucleus, so places where we can improve speech, places that we can worsen speech. And so we're just discovering this, working on this, because we want to work on Parkinsonian speech. The other way we're doing that is with this non-invasive treatment. This is TMS, or transcranial magnetic stimulation, and we're able to stimulate the brain non-invasively. And so our upcoming project is to stimulate the mouth area in the motor cortex and see if we can improve speech in patients this way. So we're trying to tackle these residual problems from all directions, and we hope that we can come up with some answers for you folks. I appreciate your attention. Thanks. Mm-hmm.